Welcome to Healthy Frontiers. My name is Dr. Bizzoni. I'm a chiropractor, and this show is dedicated to the education of our viewers. Tonight's show is Preventing Sports Injuries. My special guest is Dr. Marc Kowalsky, orthopedic surgeon. Let me tell you a little bit about Dr. Kowalsky. He's a graduate of the Tufts Medical School who specializes in shoulders, elbows, and knees. He's board certified. He has authored research manuscripts and textbook chapters focusing on AC joint reconstruction, rotator cuff repair, and shoulder replacement. He cares for college and professional athletes at all levels. He was an assistant team physician for the New York Jets and the New York Islanders. He currently serves as team physician for the USA national rugby team and locally for the White Plains, Greenwich, and Iona High School football teams. He's a fellow of the American Orthopedic Society for Sports Medicine, many others as well, and he was named as the 2015 New York Super Doctor. So, Doc, I want to welcome you to the show. What exactly is sports medicine, Doc?
Sure. So sports medicine can be thought of either in terms of the type of problems that we treat or the type of patients that we treat. Obviously, as sports medicine physicians, through work with high school and college athletes, we tend to take care of people that are playing either recreational or competitive sports. Right. But most of what we do goes above and beyond simply taking care of athletes. Right. In terms of the problems that we treat, a lot of what we deal with is injury to the soft tissues of the musculoskeletal system that happen either with sports or other strenuous activities. So those tend to include injuries to tendons, which connect muscle to bone, ligaments, which connect bone to bone, or the articular cartilage that allows smooth, friction-free movement of our joints. So any soft tissue injury, head to toe, would fall under the purview of a sports medicine physician. Within the category of sports medicine, then it gets even more complicated. Right. As sports medicine has evolved, various physicians participate in the field. I'm a sports medicine surgeon, which means I treat sports medicine injuries both conservatively and surgically. There's another group of sports medicine physicians that are non-surgical. They're primary care sports medicine physicians, and they come either from an internal medicine background, a physiatry or physical medicine background. Chiropractors certainly are in that category if they have an interest and experience in sports medicine. Yes. And emergency medicine physicians also. So there's a sort of a vast array of physicians that fall under the umbrella of sports medicine, and all of them are an important member of the team.
Yeah, great, great. So what are the more common or most common cause of springtime sports injuries? What would you say, Doc?
Well, I think that it depends on what type of patient you're talking about. Right. With our adult athletes, a lot of the springtime injuries that we see have to do with the fact that, for most of the winter, many of us find it hard to stay active. It's cold, it's snowing. A lot of our outdoor sports are off limits for several months. Right. And then once it gets warm, then all of us, run outside and start playing the sports that we enjoy. Right. And sometimes we do that without adequate warm-up and progression, and we can develop overuse injuries. Sure. I think our kids are a little bit different. They're usually playing some sort of wintertime sport, right. Even when it's cold and snowy. They might be playing an indoor version of whatever sport they choose: basketball, baseball, hockey, lacrosse. Right. So their category of injuries tend to be overuse, not because they've been resting too much, but actually because they've been playing too many sports without adequate rest. So overuse in our young kids because of inadequate rest, and overuse in our older athletes because they've been sedentary for a prolonged period of time.
All right, that's great. I have a question, a little bit. What are your thoughts on playing sports? Do you like when kids are, and we'll get back into the high school group, one sport kid, or is it better to play an array of sports? What do you think as far as health is concerned?
It's a great question. We talk a lot about it in the sports medicine community. I think one of the activities that we do in our ONS Foundation, in our not-for-profit foundation, is community outreach and education, speaking to parents, kids, coaches, and trainers about this very question. Yes. We see in our kids that they are starting to play a single sport at a younger and younger age. Right. And then within that sport, they're even choosing a specific position at a younger and younger age. And we try to educate parents and the kids themselves that specializing in a single sport and sticking with that sport throughout the year can actually be detrimental. It increases your risk of overuse injury because you're subjecting a given body part, whether it's the elbow or shoulder in a throwing athlete, for example, to the same repetitive stress. And repetitive stress in a young developing patient will inevitably lead to injury. So we tend to beat the drum of the importance of the multi-sport athlete. We feel it's critical for kids to diversify their activities, to play different sports throughout the year, which we know from examples like Tom Brady. I'm a Dolphins fan, but I still admire Tom Brady, and he's a multi-sport athlete. When he was a kid, he played many different sports, and it makes people like him a better athlete in general. You learn skills from different sports that you can then take to the other team. The other thing we know is that the risk of overuse injury goes down in the kids that participate in many different sports. But it's not only that simple, because parents may take that advice and then enroll their child in 2 or more sports in a given season. So yes, they're a multi-sport athlete, but they're still doing too much for a developing child. So in addition to being a multi-sport athlete, it's also critically important to allow that young athlete adequate rest each week, each season, and throughout the year if you're going to help them avoid injury.
Sure, totally agree with that as well. Are there differences in the type of injury seen in different sports?
There are, for sure. I think, I'm sure you can agree, there's 2 general categories, or even 3 maybe, of sports that our kids participate in. There's non-contact, contact, and collision. An example of non-contact might be tennis, an example of contact might be basketball, and an example of collision might be football and rugby. And each one of them have unique injuries involved. And then you have a separate way to categorize sports, which is whether they're overhead throwing sports or not. Obviously, the collision and contact sports have a lot more of the acute traumatic injuries. Shoulder dislocations, for example, or shoulder separations of the AC joint are commonly seen in rugby and football. Ligament ruptures, an ACL, obviously, which has become an epidemic in our young kids, can commonly be seen in our contact sports. And the overhead athlete and the throwing sports are a whole different category. When you're looking at baseball players and tennis players, they get a whole different set of injuries, typically to the shoulder and the elbow. And you could certainly talk forever about the shoulder and elbow injuries in the thrower.
I just read something in our local newspaper about in 1997 there was 0% Tommy John surgeries being done on the sports high school athletes. Now it's like 50% of these kids. So it's getting rampant.
No, I think you're right. And when you look at James Andrews' example, who's one of the pioneers of that procedure in the U.S., he himself is now spreading the word about the epidemic of Tommy John injuries, not just in general and not just in the elite athlete, but also in our adolescent throwers. There has been an exponential rise in the incidence of that surgery in those young kids. And again, there's a variety of reasons for it, but repetitive stress in a developing arm is certainly one of them.
Okay, great. Are there differences between the type of injuries in young athletes experience and those that an adult will experience?
I think there are. I think when we first meet a patient in the office and we see what type of patient they are, whether they're an adult athlete versus a child, we immediately develop a list of possibilities, and those possibilities are different depending on which patient you're talking about. As an example, if you're looking at the shoulder, older athletes have a much higher chance of developing an atraumatic degenerative rotator cuff tear, a full thickness tear of the tendons that attach to the humerus bone and help move the shoulder in space. That chance goes up with age. When you're looking at a 17-year-old athlete, for example, their chance of an atraumatic degenerative tear of the rotator cuff is basically 0%. So we can already distinguish based on that alone. If you look at the labrum, a different structure in the shoulder, which is the cartilage bumper that runs around the edge of the socket of the shoulder, well, young athletes are much more likely to develop a labrum tear, either due to repetitive throwing or due to a shoulder dislocation, whereas the older athlete is unlikely to have a labrum tear, or at least unlikely to have a labrum tear that's clinically significant.
Okay. So even with the Tommy John, right? Going back to that.
Sure.
You know, so why don't you talk about that one a little bit?
Well, you know, the Tommy John ligament is an interesting one because, you know, mere mortals like me and normal people in society really don't need their Tommy John ligament because not many of us spend a lot of time back here in the late cocking phase of throwing. The thrower is a unique athlete. They're the one person who really does need their Tommy John ligament. When you get into that late cocking phase and you're trying to develop velocity to throw the ball from the mound, you need that Tommy John ligament to provide stability to the elbow and resist the tension that occurs on the inside part of the elbow in order to throw the ball with velocity and accuracy. You know, there may be wrestlers and other unique type of athletes who also need the Tommy John ligament, but by and large, throwers are some of the few.
Sure.
When they exert tremendous force on the elbow time after time, throw after throw, throughout the season and throughout the years, in some cases that Tommy John ligament can break down. It can break down in an acute traumatic way where it all of a sudden pops or snaps off the bone, or it can fail in a degenerative way, just wear and tear over time. And we can see each variation of a Tommy John injury in our young throwers. You know, thankfully, the Tommy John ligament tear is rare in our youngest throwers, you know, our 10, 12-year-olds. We're thinking of a whole different set of injuries in that person, and you know, only if we have a high degree of suspicion for whatever reason would we ever need to go down the road of an MRI to look at the Tommy John. They develop a different set of injuries, and the vast majority of those injuries can be managed conservatively, and most of the time those kids will get back to throwing successfully. But sometimes, of course, we do see true injuries to the Tommy John. And again, thankfully, even a true injury to the Tommy John ligament or the ulnar collateral ligament of the elbow can be managed successfully with non-surgical means, which means appropriate rest. It means controlling inflammation and pain about the inside part of the elbow with anti-inflammatory medication and icing, sometimes with some immobilization, and some therapeutic modalities that our therapists can offer the patient. When the pain begins to improve, then the therapist will work with them on regaining range of motion of the elbow, strength about the elbow, and then they'll start to address some of the risk factors as to why the athlete developed an injury to the Tommy John ligament in the first place. And usually that has to do with one of two things. Many of these kids have dysfunction of their shoulder blade. Either their shoulder blade posture is abnormal compared to the healthy side, or the mechanics of the shoulder blade as they move their arm can be abnormal compared to the healthy side. And so a good therapist or an attuned sports medicine physician will identify shoulder blade problems and address the shoulder blade mechanics during the course of physical therapy. The other thing that we commonly see in these kids who have developed a true injury to their elbow during throwing is a difference in the amount of range of motion on the throwing arm, the affected arm, compared to the other arm. These kids will have less range of motion or a decreased arc of rotation on their affected side compared to the other side. So again, an attuned clinician will identify that range of motion difference and address it through therapy. And then finally we'll get them back into throwing with an interval throwing program, and then eventually back to practice and competition. And then we hand them off to the pitching coach. And we make sure that the most important part of preventing injury is taken care of, which is proper pitching mechanics. Many reasons why these arms break down is that the throwing motion is abnormal, and if you don't correct the throwing motion, they're going to be right back in your office with a second injury. So the good news is, though, like I said, especially if it's a partial injury to the ligament, most of these athletes will get back. It just may take a while. And only in the rarest case, especially in the younger child, would you ever need to consider a reconstruction of the ulnar collateral ligament or the Tommy John ligament. Again, thankfully, if it needs to be done, it's a very effective operation. In most cases, it entails reconstruction of the ulnar collateral ligament with a replacement tissue and fixing it both on the humerus or the arm bone and also on the ulna bone where it attaches. What we have to caution both parents and patients alike is that the rehabilitation after surgery takes a very long time. And it can take 15 months, over a year, to get these athletes back to their sport at the same level as their pre-injury status. So it's certainly, you have to spend time getting to know the patient. You have to work with them to understand expectations as you coach them through not just the surgery, but also the process of rehabilitation.
Right, which is so important.
For sure.
Yeah. Okay, so many athletes think they will need, that's a great answer, Doc, you know, they'll need an MRI to adequately diagnose their condition. Is that always true?
Yeah, it's not always true. And in fact, I'm sure you've probably had similar experiences with patients in the office that it is very true that an MRI is a great test.
Yes.
It is 95% accurate in showing us the structures of a given joint. It shows us everything we ever need to know about the soft tissues, the ligaments, the tendons, the articular cartilage, the muscle. But we really only need an MRI to diagnose certain conditions, and we only get an MRI if we have a high index of suspicion for a given condition. And usually an MRI is a pre-surgical test, meaning these patients have already failed a certain amount of conservative management, and we are beginning to think that this might be a patient who needs surgery. We usually get an MRI to confirm the diagnosis and to help with surgical planning. So I do spend a lot of time in my office counseling parents, counseling athletes, that for most of the things that we treat in the office, we actually don't need an MRI. Believe it or not, a good history, speaking to the patient, a good physical examination, and a simple set of x-rays can be enough.
Right.
And what I also tell patients is it's not an either-or situation with x-rays and MRI. It's not either an x-ray or an MRI. X-ray is a good first step and is sometimes the better step, especially if what we're looking at and what we're interested most in is the bone.
Right.
I describe the X-ray to them as basically a Christmas tree after you've taken down all the ornaments and all the lights and all the tinsel so that you can look at the branches.
Right.
With too much signal and too much information, you lose sight of the branches, and you need to see the branches. You need to see the anatomy of the bone before you can even think about the soft tissues. So we certainly do start with an X-ray, and then we get an MRI if we really need it.
Yeah, that's great. Great explanation. I love the Christmas tree explanation. It's great. What's the role of physical therapy in the treatment of sports-related injuries?
So, we've talked a little bit about the role of PT with ulnar collateral ligament injuries, or Tommy John injuries in particular, and I think that example holds true for a lot of what we talk about.
Right.
When we look at our own practice, and we're a practice that has a number of surgeons as a part of the group, but still only a small percentage of the patients that we see ever have an operation. Right. Most of the patients that we treat and most of the conditions that we treat, we do so conservatively, and that's even including the surgeons at ONS. So physical therapy is fundamental, and it can treat most of what we see effectively and get athletes back to their sport of choice at the same level. The physical therapy works sort of in a stepwise manner. As I explain to patients how it works, they usually start by controlling pain and inflammation, and they'll do so with some of the therapeutic modalities that they have at their disposal, things including simple ice and heat, simple soft tissue massage. They can use e-stim, electrical stimulation, or ultrasound, and then there are some other modalities that certain therapists have, iontophoresis, and as an example, laser therapy. To be honest, our therapists are more on the cutting edge with those modalities and more up to speed on the evidence to support them. But we usually defer to them on which modalities they feel would be most effective for a given patient. Once the swelling and inflammation begin to improve, then we move to the next phase, which tends to be restoring motion of the affected joint and also maintaining strength and flexibility of the affected joint. So we know for knee arthritis, for example, even in our older athletes that may be playing tennis through an arthritic knee, that maintaining flexibility of the knee through stretching program and maintaining strength of the muscles that support the knee, including the quadriceps and the hamstring, can meaningfully impact their level of pain and their function. So that in and of itself can be helpful.
Right.
And then finally, the third phase is functional therapy, which means starting to incorporate sport-specific training, starting to incorporate more dynamic exercises as you begin to think about getting the athlete back on the field.
Right, that's great. And isn't it true that it's even better to engage in a physical therapy program if they are going to have surgery, so that they're better off possibly when they're done you know?
Completely agreed. Absolutely. And obviously from a practical perspective, we always have to be careful helping the patient manage how many therapy sessions they have available to them throughout the year.
Yes.
But all things being equal, I agree with you wholeheartedly.
Yeah.
We like to get them incorporated into what we call prehab, or pre-surgical rehabilitation. Let's take the arthritis example. And even though we're talking about athletes, we know that more and more of our older athletes might be playing through arthritis. So it's important to consider. And we know that let's say they're a candidate for knee replacement. The range of motion of their knee going into the operation is the best determination of how much motion they'll have afterwards. So prehab can be helpful in that regard. Let's take ACL tears, for example, a very common injury that we treat surgically. Patients come to us shortly after the injury with a significant amount of swelling in the knee, pain, and limited motion. If you notice when our young athletes watch professional teams on TV and they see one of their players get hurt and have an ACL tear, rarely are they rushing to the OR to have that ACL reconstructed. They might be having surgery 2, 3, 4 weeks later. The reason for that is it's important to let the swelling die down and to improve range of motion and to improve quadriceps strength. We need all those things to fall in place before we even consider reconstructing the ACL. So we send them to prehab for that reason. Control the effusion or the fluid in the knee, wake that quadriceps up again, because after an injury to the knee you get a certain amount of quadriceps atony where the muscle falls asleep. We need to re-engage the quad and build up quad strength and then get their motion back. You never want to operate on a ACL torn knee that has limited motion. We need to get that motion back, particularly full extension of the knee, before we operate on the knee. So I think you're spot on with that.
Great, great. So how do you determine when surgery is required for a sports-related injury? I think we
Good
talked
question.
a little bit, but go ahead.
We certainly touched on it a little bit. I think that in a certain sense it depends on the problem, but as I mentioned, we operate on so few of the patients we see, and for most conditions we give them a chance to get better on their own first. There are two fundamental aspects to deciding when surgery is required, and oftentimes it's a collaborative approach between patient and surgeon. And number one, their symptoms, weakness, pain, should be significant enough that they're interfering with their quality of life. And for many of our active patients, that means interfering with their ability to participate in their sport of choice. So that's number one, impact on one's quality of life. Number two is they should have tried conservative management first. We should have sort of helped them through that process of rehabilitation, physical therapy, anti-inflammatory medication, ice and heat, and sometimes an injection of steroid. If they've tried those conservative modalities already and it hasn't worked, if they meet both of those criteria, then they may be a patient who's ready for surgery. There are exceptions. I think some of our acute traumatic injuries in our younger kids may require surgery earlier. For example, an ACL tear, that's an indication for surgery for our young athletes, because without an ACL, it's difficult or impossible to continue to participate in sports that require cutting, pivoting, and twisting. Without an ACL, especially if you continue to buckle your knee with those cutting activities, you can do further damage to the meniscus cartilage. And we think theoretically that your risk of arthritis might go up if you have an ACL deficient knee. So for all those reasons, in our young active athletes with an ACL tear, we tend to recommend surgery earlier. And there are other similar examples. Shoulder dislocations might be another. That's a bit of a controversial one. What to do about a young athlete who has had a shoulder dislocation? Again, a conversation with surgeon, patient, and family. We know that the younger a person is when they have their first traumatic dislocation, the more likely they are to have subsequent dislocations. So if we can predict that we have a very young patient who participates in a high-risk collision sport, who's at risk for recurrent dislocations, we may recommend surgery earlier. If, on the other hand, we have a bit of an older athlete who's had their first dislocation, but it was a fluke and they tend to participate in a low-risk activity, then we may instead go for the conservative path.
Got it. That's great, Doc. So what are the top 5 sports injury prevention tips you can give our audience tonight?
Yeah, well, that might be the most helpful
I love that one. That's great.
Question of all, and that's our goal. And again, through our foundation, that's a lot of what we talk about,
Yeah.
how to prevent these injuries from occurring in the first place, particularly in our younger kids. And I think there are a few things to keep in mind, and some of them are intuitive. I think, number one, we talked about that transition from winter to spring and going from sedentary to active. And I think it's important to develop a sensible program as you get back into sports that moves gradually and progressively from sedentary to active, and you want to advance according to your level of experience and your level of comfort and your fitness level too.
Sure.
So sensible progression would be number one. Number two, I think it's important to have adequate diet and nutrition. I mean, we don't think enough about that, but I think we need to provide proper fuel to our bodies in order to avoid injury, and staying hydrated is another example. Rest is critically important, and you can look at rest in a number of different ways. Adequate sleep. We know that adequate sleep is critically important not only to performance but also to injury prevention.
Right.
But it circles back around to what we talked about at the beginning, which is with our young athletes, adequate rest between each session, adequate rest throughout the week, and also adequate rest in between each season and in between each sport. It's critically important to incorporate that, particularly at the youngest levels, to avoid overuse injury.
Right.
The fourth one would be a strength and conditioning program, and I think this applies to all levels.
Yes.
We have a lot of good information from multiple different professional societies, including our own, the American Orthopedic Society for Sports Medicine, the physical therapy community, the athletic trainer and strength and conditioning community. Each and every one of these professional societies have offered a consensus statement that has told us that not only is strength and conditioning safe, even for athletes at the youngest levels, but it's also effective in decreasing the incidence of injury. So I actually encourage both our older athletes and parents of our younger athletes to think about a strength and conditioning program. Now, we don't want our youngest kids lifting heavy weight. We need those younger kids to be supervised. We need, again, a sensible program to be developed for them. We want them to avoid heavy lifts and maximum repetitions, and again, adequate rest in between each conditioning episode. But strength and conditioning is very important across all levels. And then finally, I think access to a provider if you ever do sense that there's an impending injury or an injury that's already occurred. So we've tried to do a little bit of this. We have something called Ortho Access in our group, which is basically 24-hour, 7-day-a-week access to one of our sports medicine surgeons. We provide it to athletic trainers and coaches around the community, and if they call that number, one of our mobile phones is going to ring, whether it's 10 at night or on a Sunday. We want trainers and coaches to have access to one of us to ask questions, so that if they have an injured athlete, they know what the next step should be. Emergency room, urgent care, or come see us in the office on Monday. And if they do happen to have an injury that's not an emergency, which is most of the time, then we make sure to get them in the same day so that we can help them with an appropriate evaluation, x-rays, and MRI if needed to get them on the right path to recovery.
Sure, and it's so important to even be able to get to the office 24/7 to be able to talk to somebody, especially if it's your son or your daughter involved in an injury. Correct?
No question. I think we can all relate to that, whether it's ourselves. I think we've all had injuries along the way, or our kids. And I think knowledge in and of itself is enough to provide peace of mind. So even if it was a minor injury that's bound to get better on its own, sometimes having a provider, whether it's a chiropractor or a physician or a therapist, through self-referrals, to be able to examine that kid and reassure the parents that they're going to be okay, or to examine the older athlete and say, I know you're training for the marathon, luckily this is minor and you'll be okay. I think peace of mind is important, and then we can get to actually steps to recovery.
Great. Doc, that was terrific. I want to thank you for being on the show.
Really appreciate it. Thanks for having me.
And thank you to our great audience, and we look forward to seeing you on the next show. Thank you.